Hello, my name is Amy Rogerson. I'm co-creator of the course Managing Osteoarthritis Together in Movement. I'm here today to introduce your course number 2. So this is a very particular course where we want to demystify, review some of the information available about osteoarthritis and what might be leading to your pain related to this condition, and give you a little bit of an idea of how we're going to address managing pain. So let's get right to it here. Here's an overview of the content that we're going to be reviewing today. So the first thing that's up, we like to do a bit of an exchange. We've questioned participants about this particular context on several occasions in other courses. So first, we want to get a perception of what your experience with osteoarthritis is. The next thing is we're going to reframe your beliefs. So we're going to review what it is, osteoarthritis. We're going to look at what causes pain related to osteoarthritis and hopefully give you more information to have a better idea about how to manage your condition. We're going to talk about modifiable risk factors. This is the stuff we're going to act on to be able to have an impact. And we're going to review morning routine. So when we talk about osteoarthritis, it's not just the joint that's in pain, it's the whole person that we're taking into consideration. So I want to review some of the themes that have come back recurrently with other courses that we've held. In particular, there's a lot of people who share about how the impact of the diagnosis has changed their perception about their function. Some people have expressed that it's led to a certain level of isolation in terms of not being able to do certain activities, or even socially, not being able to, say, keep up with their friends in terms of the activities they previously liked to do together. Some people express as well some apprehension or fear about moving. And other people also say it's a bit of an adjustment in order to recognize where they're at in terms of their function, and often they will go beyond their capacity and then pay the price for it after. So they're looking a lot of the time for some guidance in terms of how to better manage their condition as well. So I'm sure you recognize yourself in these themes. You may have the opportunity within your group to exchange about how you feel in the context of your condition. And I think that's a really powerful tool in terms of realizing you're not alone in what you're feeling. And that group effect alone has a big impact as well. The other thing is, we want to get a better understanding of what your understanding of osteoarthritis is, because there's a lot of misinformation. Some people have some concepts that they thought were true that I'm hoping will demystify, debunk a little bit in more detail. So to kind of clarify things, we're going to start our first slide about, what is osteoarthritis? So the first slide here, there's lots of terms: arthritis, osteoarthritis, osteoarthrosis, osteoporosis. So let's first clarify a little bit in more detail what these conditions are. So when we look back at the roots of the word arthritis, for example, the first 5 letters, arth, is actually representing the word joint in Latin, and itis actually represents the word inflammation. So joint inflammation, in summary, is what the word arthritis means. So here's the thing. There's different forms of arthritis. The first one I want to clarify a little bit is inflammatory arthritis. So here what we're talking about is not only inflammation of the joints, but it's the root cause behind what's causing the inflammation. So to better understand that, essentially, there's a disorder of your immune system. So your immune system that's not only there to protect you against illness or disease has kind of a misdirected response, and it starts to essentially aim its target at your joints, which can lead to some degenerative changes within the joint and inflammation. So here we're talking about not just a localized problem. It's a more widespread root of the problem, and it includes an immune function component. So these types of arthritis, inflammatory arthritis, include things like rheumatoid arthritis, ankylosing spondylitis, gout, psoriatic arthritis as well. Often patients with this type of diagnosis will be followed by a rheumatologist, and typically some of the medication courses that might be used for these patients would include things that suppress or reduce the reaction of their autoimmune system, so immune suppressive medications. So this is a little bit different than what we're talking about when we're talking about osteoarthritis. So we still know that it involves the joint. So there's degenerative changes, and we're going to rehash maybe the term degenerative changes a little bit further on in the slides. But there's also an inflammation component, but that's typically caused by an overload. We know it's a little bit broader than this, and this is, progression in the research that's come out over the last maybe 5 or 10 years, saying there might be this low-grade inflammation, chronic inflammation that's contributing as well. But in general, we're talking about a localized problem. It's the most common type of joint pain in people over 45 years and older, and it typically involves knees and hips, but can also involve certain joints within the hands, etc. So this is what we're talking about in the case of osteoarthritis or osteoarthrosis. And then there's osteoporosis. So osteoporosis is really a completely different illness or condition, rather. Osteoarthritis involves the density or how hard your bones are. Often patients with osteoporosis, they can be more typically seen in women in a perimenopausal or postmenopausal, because estrogen hormones affect the absorption of calcium in our bones, which is what makes it hard. And here we're talking about a decrease in that bone density, or so your bones become more soft, if you will. And we're specifically talking about risk of fracture in particular. So here we're not talking about joints per se at all. We're really talking about the density or how hard your actual bones are and the risk of fracture associated with that density. So we're really in a different ballpark altogether. So hopefully that clarifies a little bit what we're going to be using in terms of terms over the next little while. So we know it's, really typical. People 45 and up will have, hip joint pain. It's the most common condition causing joint pain. What we used to think was that it was mostly related wear and tear, cumulative loading. It would also be in the context of having had a history of injury. It was a very mechanical view of what's causing the pain. So my cartilage is wearing, and therefore that worn cartilage is causing pain. What we know now is that it's a little bit more complicated than that. There is more research coming out looking at the context in which this joint pain can flare up, for example. And it appears that there's a link between what we call metabolic syndrome, so other risk factors that regulate your metabolism. So there could be cardiovascular risk factors, there could be high cholesterol. We know that patients who tend to be overweight or obese that have higher percentage of body fat typically have higher levels of generalized inflammation in their body. So the increased weight also has an impact, but not just on the mechanics, more in terms of the inflammation that might be going on. And there are still really good evidence to say, history of injury, for example, is going to increase your risk of having some arthritic change. So it's a little more broad than what we initially thought, which, gives us more things that we can actually address. So there's lots of facets that we can work on, that we can be proactive and cause actual change to help us manage our condition as well. So there's a lot of positive hope here in terms of intervening on any of these risk factors to try and mitigate your pain. So why do my joints hurt exactly? So if we're saying that it's not just the mechanics of the load, then what is it exactly that's causing the pain? So we do know that overload is a risk factor. So our tissue has a certain tolerance to load, and if we go beyond that, then we end up overdoing it and causing pain and in some cases inflammation. So overload still has a big impact, so going beyond what our tissue's tolerance is. We also know that the inflammation inside the joints doesn't only stay restricted or limited to just the structures within the joint. It can actually propagate to tissues around the joint. So the way I like to explain this is that it's kind of like my little toxic soup. As that inflammatory response sets in, it's a fluid, there's a rush of what we call histamine response and cytokines, which are these little chemical irritants, if you will, that even come and sensitize the nerve tissue in that area. So now you've got, kind of these irritated nerves that also contribute to part of your pain. So the thinning cartilage itself, though, and this is where, it kind of, we have to rethink or reframe things, is that the cartilage itself doesn't have nerve endings in it. So to say that the pain is coming exclusively from the cartilage that thinning is actually not accurate. So if it's not innervated, what is then causing your pain? So what we do know is that there's this surrounding tissues. So around the actual joint surfaces, there's a capsule with ligaments in it that hold the joint together. And then in addition to that, on the outer layers, you've got muscles and tendons that cross the joint, and bursas, which are little cushions that help tendons glide essentially over bony surfaces. And those structures, in addition to the bone underneath the cartilage that has some thinning, that this is what's called subchondral bone, those tissues are innervated and can cause pain. So we want to make sure that the perception is clear that it's not just the cartilage, and the cartilage in and of itself doesn't actually have nerve receptors in it. Now, again, it gives us lots of opportunity to intervene on the state of these tissues around the joint. And the last point is that we might also have some pain that's referred. So referred pain would be pain that's felt in an area that isn't local to where the tissue irritation is. So, a really general kind of example of this could be like sciatic pain, where you have pain radiating down your leg, and it's actually not the structures down your leg that are irritated. It's actually something in the nerve root in your spine, for example, or even some of the structures in your spine that you're causing the pain to refer or radiate down your leg. So people with, for example, knee osteoarthritis will sometimes have pain down the front of their shin. And some patients, for example, with hip osteoarthritis will have more diffuse kind of bum and groin pain, and sometimes it will radiate down their leg as well. So those are the structures. Here's where we want to just change a little bit the terminology. So this might seem like a very basic thing, and what word we choose, how important is that? But the thing is that if we were to take x-rays of everybody, basically 40 years and up to 40% of those people would have thinning cartilage, osteophyte formation, some degenerative changes maybe in the meniscus as well. So they would have these age-related changes, but they actually have no symptoms. So no pain at all associated with it. So that's where degeneration causing the symptoms is something that we have to rethink. So we know we have these age-related changes over time, but whether or not they're actually associated with what's causing your pain are a completely different question as well. So this is where we want to make sure that there's hope. The state of your x-ray is not going to dictate necessarily whether or not you're going to be limited. And it also means that it's not a linear thing. So the amount of degenerative change doesn't equal symptoms. And it doesn't mean that what you see in one x-ray is necessarily going to be a progressive deterioration over time with a loss of function. So there's not a good link, which, to me, gives us lots of hope in terms of how we're going to manage this. So just to summarize, changes on imagery are seen in 40% of asymptomatic people. We know it's more complicated than just the structure. We have to consider the context of your whole body, and there's lots of things we can do to address when your joints become painful. Here's an awesome picture of a joint. It's so beautiful. I might be biased, but you can see the ends of the bones here. And on the ends, the green is the cartilage, and that's the tissue that I was explaining becomes thinned with age-related changes, but doesn't necessarily provoke pain in of itself. Then you've got this blue liquid around, which is your synovial fluid. So the synovial fluid is like a lubricating substance that allows our joints to move and glide smoothly. And the cool thing about synovial fluid is that it's only going to be secreted when we're actually moving. So a nice example of this might be, you get out of bed, you haven't moved much all night long, and your first steps out are kind of like stiff and squeaky or just a little bit more sore, painful. And then as you get going, oh, okay, now I've kind of got my joints up and moving. That's literally because as you move and you load through your joints, you're actually going to get that synovial fluid, that liquid to be secreted, and it'll help lubricate your joints. And the only thing that really does that is movement and loading. The other thing that's really cool is that the cartilage of itself is dynamic. So even though we have areas of age-related changes and thinning, the rest of the state of the cartilage can adapt. So the cells are not static. We know that when we mechanically load the cartilage actually becomes more resilient, more robust. It becomes thicker and more tolerant to loading. And that only happens when we actually stimulate the cartilage by loading on it. So weight-bearing exercise with movement. So these tissues are not like a static thing that's going to be stable over time. We can actually create change and adaptation in those tissues. And then you can see all the structures around that I was mentioning before that sometimes are the things that become what we call sensitized or irritated. The bursa above the joint can become inflamed sometimes. The tendons, the joint capsule that kind of wraps the whole thing and keeps it together and stable can also become irritated. So there's lots of positive here. We say, motion is lotion is kind of the catchphrase that one of our really guru physios coined a long time ago. And it does give an actual picture of the dynamic nature of our tissue and how it can change. So here we're going to talk about risk factors. There's certain things that we can change and there's certain things that we can't. So as you probably already know, some of the risk factors that are considered non-modifiable are our age, our gender, our family genetics, our previous history of injuries. So those things, are things that we can't act on. So they won't be the focus of our talk today. But what we will focus on are the modifiable risk factors. So the good news is there's lots of ways we can intervene. And this is very going to be a quick overview of all the things that you're going to see further down in the course at each session in a bit more detail. So this is a really big take home that you probably are a little bit aware of, but maybe not the effect of exercise on this modifiable risk factor, but essentially joint loading affects symptoms. So just in a very simplistic way, what I like to explain is that even if my finger is not injured, I don't necessarily have osteoarthritic change or age-related changes in this joint. And if I held my finger under a load at end range for the rest of the day, I would probably end up a little bit uncomfortable by the end of the day. And I might even, if I held it there long enough at, a sufficient enough load, I might actually cause some overload and then some inflammation because of it. So even in a tissue that's really robust and healthy, too much load can lead to an irritation. So when we talk about loading and osteoarthritic change, there's a few reasons, but overall our loading tolerance of our joint is a little bit diminished from those age-related changes. But the thing is it's adaptable. So again, its tolerance to load isn't static. We can intervene through very graded exposure to exercises and activities to increase the joint's ability to handle more load. So it's dynamic. Not only can we act on the cartilage health and the synovial fluid just by exercise, we can also affect the muscles around it. And we'll talk about that a little bit more in the next slide. So the good news is your tissues are adaptable. It does not matter what your starting point is. Anyone can make improvements. And those improvements can lead to better function and doing the things that you like to do. Okay. So the next element is weakness. So there's a lot of really good research where, regardless of whether it's hip osteoarthritis or knee osteoarthritis, patients that have weakness in their quadricep or their thigh muscle or their gluteal, their buttock muscles, will tend to develop more symptomatic or painful age-related changes. So weakness has a really big impact on whether or not your joints can take on more load and whether or not, therefore, they become irritated. We don't really know if it's chicken or egg type of situation. So meaning, does the pain then cause weakness? And because it's weaker, we end up with more pain, or maybe there's weakness before that leads to more age-related changes, and therefore that causes more weakness, and it makes a bit of a vicious circle. But regardless of which came first, what we know is that if we intervene to increase the strength capacity of these muscles in particular, it reduces developing symptoms with your osteoarthritis. So again, this is something that is really, really important, and it's one of the main emphasis that we're going to put on in our course, is teaching you how to figure out what is your starting point and how can you gradually load it so you can become stronger. Okay. I don't think it's any surprise. This is, something that comes back. Most patients will say, I know my doctors told me that I have to lose weight to reduce my pain in my joints, because more weight means more load on my joints, and that's what creates pain. So the thing about this is that we know now, with what I shared you before, it's not just a factor of the mechanical weight on your joint. It actually has a greater impact on your overall inflammatory load in your body. So even small changes to eating a more balanced diet, a little bit healthier alternatives, a little bit of weight loss that has as a consequence of eating more healthy food and moving a little bit more, any little gain that you can make here will have a positive impact. So, but it's broader than just, I need to lose weight because it's more load. It's actually about looking at overall level of inflammation. So we know now, and this is going to continue to grow over the next, 10, 20, 30 years, that lifestyle choices will have a bigger impact. And it's not just because of the impact in terms of overall load. And generally speaking, more movement is also going to make us feel better for other reasons. And we'll touch base on this as well. So what factors affect your pain? So we've talked about, the tissues that might be involved. We talk about how it's broader. There might be a little low-grade inflammation, loading, strength. Those are all very mechanical things. But if I'm to ask you, what other things affect your pain levels? I'm wondering if you might come up with a few other examples. So what about if you really haven't been sleeping well for a week? What happens then to your pain tolerance level? What about as well if you're super stressed, if you're in a period of time where you've got just too many balls to juggle in the air and you're feeling overwhelmed? What happens to your pain then? So we know now that we need to have a more holistic view of helping patients and their whole being manage these conditions. This particular slide is pulled from a 2017 article, so not that new really anymore, looking at first line interventions, quality care for helping patients manage osteoarthritis. And there's 4 facets here. So we've talked a lot about the biological component, but as you can see, the psychological, sociological, and the behavioral components also are important things to address when we're talking about pain related to age-related changes. So psychological could be your coping strategy, if you're stressed, if you have apprehension about movement because of your condition. Sociological could be also your support system, your network. Does your significant other, validate and recognize that you're struggling from one day to the next with this? Or are they a bit dismissive and they can't really understand it, or they don't have a good perception of what you're going through, and that affects you? And then the behavioral is more the context of just overall habits, how you're going to manage your day. If you have, overall a healthy lifestyle, are you able to be proactive and put things in place as well? So there's lots of elements to why we perceive pain. One of the samples that I give in terms of putting this into a very basic kind of comparison would be, if I'm at a party, I'm surrounded with my friends and everyone's having a great time and we have had a great meal together an evening, and there's a coffee table in the middle of the living room, and I get out quickly to go and grab a drink, and I catch my foot on the corner, I stub my toe, and the pain is like, how stubbing your toe feels. It really hurts. But, I'm surrounded by my friends and we're kind of laughing about it. Everybody's like, are you okay? Oh my goodness, geez, you really hit that hard. And you know what? My pain kind of subsides. And I want to put the same impact force now, but at a different context. So I'm up in the morning, I had a terrible night's sleep, I'm super late for work or for an appointment, and I got to stop at the bank. I totally forgot to pay off this thing and it's past due. And I get up and I from the couch with my coffee and I go around the coffee table, I stub my toe. So same mechanical force, but what do you think my perception of my pain is going to be in that moment where I'm living all of these other contextual things that are adding to my overall load? And I'm willing to bet that your perception of your pain would be different in both of those situations, regardless of the impact being exactly the same. So this is just a very simplistic way that I like to give people as an example of context and how it affects our pain perception. So challenging our fears and our beliefs will also have a huge impact on how we manage our pain. So an example of this could be if you've experienced pain, for example, the last time you went to the grocery store, and now you're starting to get concerned that if you can do that again, you're going to experience that pain, and that apprehension or fear of feeling pain again causes you to change your behavior and limit what you're doing, which in turn can lead to some deconditioning and also put more risk on creating more symptoms. So your way that you react to stress and your perception of your pain and your apprehension regarding your pain has a huge impact as well. So when we know that we can have an impact, not only from just changing our perception and our behaviors, but through our actions as well, it becomes much more motivating. The other thing that's really interesting is there can be context. So contextual things like the environment that we're living in has an impact as well on our pain perception. And it's to the point where we know that specifically time outside in nature can have a huge impact in our pain. So as little as 20 minutes a day or 2 hours a week has spending time outdoors in nature can have a huge overall impact on your well-being and therefore your ability to cope and to manage your pain. It's to the point where we know that it's so good that the government has put in a project called Prescrit Nature, where we can actually, as health professionals, prescribe time in nature to our patients. So the literature is there. This wouldn't be an incentive if the impact wasn't this significant. So we live in such a beautiful area in the Eastern Townships. We're so fortunate to have all these beautiful views in our backyard. So we want to really encourage people, just even sitting on a bench outside in nature will continue to have these effects on your well-being. So we're so lucky to be able to have access to this. And so we really want to encourage people to be aware of the positive impacts on pain perception through spending time in nature. Isabel is in this coulter going to go over course 2, a morning routine. So here we're going to tap into the whole motion is lotion little slogan, looking at creating a routine and a structure around moving daily to help those joints stay lubricated and keep the health of your joints and your cartilage as good as possible. Thank you for your attention. I hope that I've clarified some of the details about your condition, what leads to pain, and that you have a better perception about what you can do, and that you have a positive focus on all those modifiable things that we discussed today. Thank you for listening.